So one of the topics that I've been trying to avoid to do on the channel for a very long time actually is nephrotic syndrome, owing to the fact that this is a very, very long topic and it's going to be associated with a lot of details. So it's very hard to super summarize it so that it can fit in one video that is very short. So I thought of an idea of actually breaking it apart into small components such that I can teach everything in these small components, and at the end of these small components I can give you an overview or a summary, which will be a much longer video so that you can get the best of both worlds. So let's talk a little bit about nephrotic syndrome. Grab a piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at nephrotic syndrome, with the focus mainly being on the minimal change disease. If you haven't yet subscribed to the channel, what are you waiting for? Hit the subscribe button, hit the bell notification icon to be receiving notifications of such amazing content every time I post. Grab a piece of paper, grab your pen, and let's go. So before I go into details talking about nephrotic syndrome, you first need to understand about the kidneys. Remember that each and every single organ has a functional tissue, which is what we refer to as the parenchyma. And then it has supporting tissue, which is what we refer to as the stroma. Each and every one of us is a millionaire in our own right because we have 1 million nephrons that are going to be there, over 1 million nephrons in each kidney. And these nephrons are the functional unit of the kidneys, are going to be functioning in the purposes of pretty much filtering out the waste material from the blood. The nephron consists of different parts. One such important part is what's known as the glomerulus. Remember that this glomerulus is going to just be a collection of capillaries that are there for the purpose of filtration. So these capillaries are going to be formed by one vessel that is entering into the glomerulus, which is known as the afferent arteriole, as depicted on this picture here at the bottom. So this one, as you can see here, is entering into the glomerulus. This is what we refer to as the afferent arteriole. Here it's depicted at the top here. This is what is referred to as the afferent arteriole. Then, as it enters into the glomerulus, it divides into these smaller capillaries which have holes in them, which are known as fenestrations, which allow for certain filtration to happen. So there are capillaries, the glomerular capillaries that are there forming this network of capillaries, which is what we refer to as the glomerulus. And eventually everything is going to converge into an efferent arteriole, which is this one here, the efferent arteriole. In this case here at the bottom, this is the efferent arteriole. Now, these glomerulus are surrounded by some sort of connective tissue. The special type of connective tissue that surrounds these capillaries and is found in this glomerulus is what we refer to as mesangium. That's the type of capillary. So the capillaries are going to be, rather connective tissue. The capillaries are going to be partially attached to the mesangium, which is pretty much, think of it like the connective tissue that is there. And surrounding this glomerulus, you have a capsule there, which is formed, which is known as the Bowman's capsule, into which you're going to have a Bowman's space where all the things that are going to be essentially filtered out are eventually going to pass through the renal tubule. So starting off with the proximal tubule. So remember that inside this glomerulus, these capillaries are going to be filtration barriers, and they're going to have a basement membrane, because remember that the cells which are just facing the lumen of the capillaries, these are endothelial cells, and remember that they have interendothelial gaps, and these endothelial cells are going to sit on a basement membrane, so they're going to be laying on a basement membrane, and this basement membrane largely is going to be consisting of type 4 collagen. Now on the other side, or the other aspect, you have these special type of cells which have their food processes that are attached to this filtration barrier. These food processes are referred to as podocytes. So they are pretty much the epithelial cells, what we call the visceral epithelial cells. They're going to have these food processes which are known as podocytes, which are attached. And in between these podocytes, there are also going to be spaces in between. This is very important for you to actually remember, because the filtration barrier is going to be made up of the following cells. It's going to be made up of the epithelial cells of the glomerulus capillaries. It's going to be made up of a basement membrane. It's going to be made up of the foot processes of the epithelial cells, which are pretty much the visceral epithelial cells. And in between these are going to be certain spaces and even certain other compounds that have a certain charge that prevents certain things from filtering out from the bloodstream. This is like a basic appearance. So here is what a glomerulus looks like on histology. As you can see here, you have this entire thing as the glomerulus, the nephrotic capillaries there. Adjacent to it, here you have the macula densa. Here you have the proximal convoluted tubule. Here you have the distal convoluted tubule. Then, of course, you have the basement membrane where these cells are going to be sitting on. Now, remember that your basement membrane largely is going to have a thickness of about 250 to 300 nanometers, and the spaces, like I told you, in between the foot processes are going to be referred to as a filtration pores. They're about 20 to 60 nanometers in size. And remember that anything that is bigger than these filtration spaces means that it's not going to pass. So it means that, number one, your filtration barrier is going to be a barrier to size. It means that proteins that are very huge are not going to pass through. Structures that are very huge, red blood cells, they're not going to be able to pass through normally. Larger proteins like fibrinogen are not going to be able to pass through normally. Then the endothelial cells, like I told you, on the luminal aspect of the basement membrane are going to have these windows, which is known as fenestrations. It comes from the French word fenestroir, meaning window. So this is going to have a diameter of about 70 to 100 nanometers. So in terms of your basement membrane, it's going to be arranged in these three zones. And like I said, it's going to have type 4 collagen. And it's going to have a lot of proteoglycans, which are negatively charged at physiological pH. So they're going to be consisting of heparin sulfate. Now, this is very important because this filtration barrier is now going to be a barrier to both size. It's going to be a barrier to both charge as well. Because remember that even though albumin is a very small protein, it does not normally get filtered out in the kidneys in large amounts because the albumin has negative charge at physiological pH and physiological conditions. So it gets repelled by this. So in some cases, you may lose this negative charge. Albumin gets filtered out easily. You're losing this albumin in the urine. Sometimes the spaces in between the food processes can efface, they can be damaged, and this can lead to filtration of those proteins through that filtration membrane. So remember that the glomerular filtration barrier is going to be consisting of a fenestrated endothelium, which is pretty much the layers of the cells of the capillaries of the glomerulus. It's going to have a glomerular basement membrane where these cells sit on, and then of course these terminally differentiated visceral epithelial cells, which have these food processes that are known as podocytes. And remember that the podocytes are going to dictate the size, selective nature of this filtration barrier. Now, having spoken a little bit about that and you having understood that, remember that glomerular disease is going to be largely divided into two main types. So you have what is known as glomerulopathies, which I will be talking about here in this particular lecture, with the main focus being on minimal change disease, which is what we see commonly in the pediatric population. So here there is going to be no evidence of inflammation in this case. There is no inflammation taking place. Then remember, anything that ends in itis in science means there is some sort of inflammation. So you have another group that are known as glomerulonephritis. Here there's going to be some sort of inflammation of the glomeruli. So there is going to be an overlap between the glomerulopathies as well as the glomerulonephritis. So in terms of the glomerulopathies, which are the ones that I'm going to be talking about, they're going to be characterized by, number one, primarily they're going to be driven by some immunological mediated injury. Even though there is no inflammation that is there, but the underlying damage that's going to be there is going to be primarily mediated by the immune system. So there's going to be some renal intrinsic damage, and usually this is going to be following this primarily immunological mediated injury. Second thing is that often it affects both kidneys. You will rarely see it affecting one kidney. It's going to affect both kidneys in a similar fashion. So it is this bilateral symmetrical involvement. The third thing is that there may be some secondary mechanisms that may cause injury to this glomeruli. For example, initially an immune insult can happen, such as The initial injury can come into play following the initial immune injury, something that happens after. For example, you begin to deposit fibrin afterwards. Platelets begin to aggregate. Neutrophils can infiltrate those tissues. Free radicals can actually form. Then the other thing is that usually the lesion that you get in the kidneys may be part of a bigger disease. For example, a patient may have some renal involvement, but as part of a disease such as a systemic lupus erythematosus or an SLE. Some important terminology I want you to keep in mind. When we talk about focal, this just simply means that some of the glomeruli are affected, not all of them. Some of them are going to be showing the lesion. When you talk about diffuse, or when we use the term diffuse or global, meaning more than 75% of the glomeruli are going to have a lesion in the kidney. When you talk about segmental, it means only a part of the glomerulus is affected. So most of the times, if you see a lesion that we say that it's focal, meaning that some of the glomeruli are affected. Even in those glomeruli that are affected, part of those glomeruli are going to be affected. A segment of them are going to be affected. So, for example, a focal segmental glomerulosclerosis. When you talk about proliferative, it means that there's an increase in the number of the cells. Maybe there's some sort of hyperplasia that's affecting one or even more of the resident glomerular cells that may or may not be associated with inflammation. Because as you can see, some proliferative conditions that are implicated in nephrotic syndrome will also be seen in nephritic syndrome. Then you may have some membrane alterations where there are capillary wall thickenings because you deposit this immune complexes. You may sometimes have alterations in the basement membrane. When you talk about crescent formation, simply there's this epithelial proliferation with these mononuclear cells that are infiltrating the Bowman space. These are some important terminology that you must understand as we go into talking about details of the glomerulopathies. So remember that these ones are going to be considered as immunomediated disorders. They're going to be affecting both kidneys most of the times, and it's going to be a cell-mediated thing. So it's going to affect the T cells, the macrophages, the dendritic cells. It's going to also affect the humoral-mediated immune system. It's going to affect the antibodies, the immune complexes, and the complement. It's going to affect the inflammatory mediators. So it's going to involve certain cytokines, certain chemokines, certain coagulation cascades. I won't go into details of that in this particular lecture because I will talk about this a whole lot in the other conditions and even when we talk about the summary of nephrotic syndrome. So remember that this response is going to be targeted towards a certain antigen. So this is an antigen that may be present in the basement membrane, for example. It may be present in one of the components of the glomerulus. So particularly when the glomerulopathy complicates an infection, for example, or during someone having a neoplasm or someone taking certain drugs. We have seen that there is some sort of genetic susceptibility even in individuals that are exposed to certain environmental factors. So some human leukocyte antigen genes like A1, B8, DR2, and DR3. You may also have certain drugs like hydralazine, chemicals like gold, silica, hydrocarbons, or even infectious agents. Now, how do we classify these glomerulopathies? You have four main groups, if you can think of it like this. So you have the nephrotic syndrome, which is what we'll talk about here. They have massive proteinuria. They're losing proteins in their urine, more than 3.5 grams of proteins per day. They may be losing predominantly albumin because it's the smallest protein. They'll lose a lot of albumin. So it means if they lose these proteins, they are losing that oncotic pressure in their bloodstream. And this is going to lead to edema. So they may have edema and some certain compensatory mechanisms that will happen in the liver. You start to synthesize more lipoproteins. They'll have this hyperlipidemia. You have this lipiduria as a compensatory mechanism. You may have acute glomerulonephritis, which is an acute nephritic syndrome. So here they're going to have this hematuria. They'll have these red blood cell casts or these dysmorphic red blood cells. They have this proteinuria, but it's not enough for you to consider it as nephrotic syndrome. It's less than 3.5 grams per day. They may have edema. They may have hypertension. They may have transient renal impairment. You may also have a rapid progressive glomerulonephritis where they get this acute nephritis, but it's very progressive. They progress into renal failure over several weeks. So they may have this focal necrosis with or without crescents actually forming. They may sometimes have this asymptomatic hematuria and proteinuria. Sometimes it may be both. So they may fall into one of these four categories. So now let's talk a little bit about nephrotic syndrome before we dive into looking at minimal change disease. Remember here you have some sort of injury that is happening to the filtration membrane. You lose those charges. Those negative charges I told you on the basement membrane are lost. The food processes become flattened. They become effaced. So it means proteins like albumin can easily leak out in the urine in large amounts. So you're going to be losing a lot of proteins, predominantly albumin, more than 3.5 grams of proteins in urine over 24 hours because of this glomerular disorder. Or you can get a random spot protein to creatinine ratio that is greater than 3. This is often characteristic of nephrotic syndrome. They'll have edema because they have lost these proteins. They have lost this oncotic pressure, this osmotic pressure that is meant to keep this fluid in the bloodstream. So the fluid component of blood can easily leak out and get trapped in the interstitium. So they often tend to get edema. They may get this periorbital edema. They may get this generalized edema, which is known as anasaka. Sometimes they may even have swelling of the scrotum in the males. You may have hypoalbuminemia, which is low levels of albumin for obvious reasons. And of course, high levels of lipids as a compensatory mechanism. It does occur at any age, but it's very common in children, especially those that are presenting with minimal change disease. So most commonly those that are 1 year, 6 months to about 4 years. And often there is a fraction that's known as congenital nephrotic syndrome, which is going to be seen in the first year of life. In those individuals that are less than 1 year, more boys are affected than girls, but above this age, it's going to be equal incidence in both girls and males. You may divide it as primary, where we really don't know what is the cause. Often it's idiopathic, it's immune mediated. Or secondary, which may be secondary to something, is secondary to a much bigger disease. So the primary nephrotic syndromes are the minimal change disease or minimal change nephropathy, which we will discuss in this particular video. You have the focal segmental glomerulosclerosis. You have the membranous nephropathy. You have the membranal proliferative glomerulonephritis. The last two, especially the membranal proliferative glomerulonephritis, can actually also be seen as a nephritic syndrome. Then in terms of the secondary causes, these ones are accounting for less than 10% of childhood cases, but more than 50% of the adult cases. So they may be in the background of a diabetic nephropathy, preeclampsia in older women. We don't want to see this as a secondary cause in pediatric population, but I will leave this video tagged as well as in internal medicine because I think it is also relevant. You may have amyloidosis, where you have deposition of these proteinaceous substances in about 4% of the cases. It's one of the things that goes under-recognized. You may have an HIV-associated nephropathy, but often this is going to be associated with the focal segmental glomerulosclerosis. So in terms of minimal change disease, remember that this is a nephrotic syndrome very common in children, 4 to 8 years of age. 80 to 90% of the childhood nephrotic syndrome is going to be attributed to minimal change disease, which is why I wanted to start by discussing this particular primary cause. So it can also occur in adults, in about 10 to 20% of adults, and often the cause is unknown, but it may be related to certain drugs like NSAIDs or certain cancers like Hodgkin's lymphoma. In terms of the clinical features, because they're losing this albumin in their urine, they're going to have loss of oncotic pressure, so they may have the periorbital edema. It's often quite worse when they wake up from bed. They may have generalized swelling. They may have scrotal swelling. Because they're losing these proteins in the urine, they'll have this frothy urine, and sometimes they may lose complement C3b, so they'll have recurrent infections. They get infected with encapsulated organisms. It's very important to give them a pneumococcal vaccine. They may sometimes lose transferrin in their urine, so they may have an iron deficiency anemia, which may also be related to anemia of chronic disease. They may sometimes lose antithrombin 3, which are pretty much these anticoagulant proteins that can predispose them to develop DVT. And because of these compensatory mechanisms that are there, they may have accelerated atherosclerosis. There is no hypertension or azotemia that is associated with this type of minimal change disease, especially in the pediatric population, but they may have microscopic hematuria in about 20% of the cases, but it's much more common in adults. Remember that azotemia can be seen in the secondary causes, and often it's seen in patients that are above 60 years, so I won't go into details of it. And remember that the main protein that you're losing in the urine is albumin, and generally because you lose those negative charges that are there on the basement membrane because you've lost those proteoglycans, and also effacement of the food processes. So in terms of a diagnosis in adults, those that have idiopathic nephrotic syndrome, you want to get a renal biopsy for them. But in children, the diagnosis is going to be suspected, and you should also even start treatment if you see that this child has sudden, unexplained nephrotic range proteinuria, and they're losing mostly albumin. They have a normal renal function. They have non-nephritic urine sediments in their urine. Then in some cases, you may get these atypical presentations in both adults and children, so you want to do a renal biopsy. Of course, don't forget your other investigations like your renal function test, your full blood counts, and all those other supportive investigations. When you do your electron microscopy, you may see edema with swelling or effacement of the food processes of the epithelial podocytes. Like I told you, you get those being flattened. There may be some, the complement and even IG or immunoglobulin deposits may be absent. So when you do immunofluorescence, you get a negative result. Although the effacement is not observed in the absence of proteinuria, the heavy proteinuria may sometimes can even be seen even though you have normal food processes being seen on the electron microscopy. So here's a picture showing you the various immunological glomerular diseases. As we can see here with the minimal change disease, we have the food processes effacement. So these food processes that are supposed to be there, we can see that they are effaced. This is what's happening here in the minimal change disease. Forget about what's happening here in these other conditions because we will talk about them when we look at these various other conditions later on. How do we manage this baby or this child? So generally, there are some general measures that you could do. You could start your patients on corticosteroids. If they are steroid sensitive, well and good. There's a way in which we do the cycles. If they're steroid resistant, we can actually consider giving them other drugs like cyclophosphamide or cyclosporine, calcineurin inhibitors like tacrolimus. You may even have mycophenolate. You may even give them some rituximab. So generally, you want to control the proteinuria, so dietary restriction of proteins. So generally, the potential value of this restriction of the diet in proteins for reducing proteinuria must be balanced with the risk of you not tipping this child into malnutrition. You can give them some ACE inhibitors to decrease the proteinuria because they will decrease the glomerular filtration pressure. They do also help control the proteinuria. They help prevent the progression of the disease. They also help monitor the blood pressure. So generally, you want to control the blood pressure. The ratio here is for adults because remember that blood pressure in children must be tailored according to the age of the child. There are blood pressure charts that are there that you should look at. Then you want to treat the complications. So if there's any edema, salt restriction, give them some diuretics. For those that are resistant to the diuretics, you may consider giving them an albumin infusion. If they have sepsis, remember, these are patients ideally that you want to cover with the pneumococcal vaccine. Cover them on antibiotics, get your appropriate cultures. For thromboembolism, give them some anticoagulation, your low molecular weight heparins. For those that have hyperlipidemia, statins could be used, though in children there's a bit of some controversy in terms of the use of statins. Then vitamin D supplementation can also be given. And remember, if there is a secondary disease that is there, you want to treat that. You want to identify that and you want to treat that. In terms of corticosteroids, remember that in some patients, they may actually undergo spontaneous remission in about 40% of the cases, but most actually do need some corticosteroids. So about 80 to about 90% of the patients will respond to this high-dose corticosteroid. So you want to give them prednisone, about 60 milligrams per square meter orally for about 4 to 6 weeks in children, and 1 to about 1.5 milligrams per kg orally once a day for 6 to 8 weeks in adults. So about 40 to 73% of responders will actually relapse after this. So for the patients who respond, for example, the proteinuria has stopped, and or a diuresis, if edema is present, has been given and they have responded quite well, you should continue the prednisone for another 2 weeks and then change them to a maintenance regimen to minimize the toxicity, because these have a lot of toxic side effects. So that's about 2 to 3 milligrams per kg on alternate days for about 4 to 6 weeks in children, and then for 8 to 12 weeks in adults. Then you taper them off during the next 4 months. So sometimes you may get a more prolonged initial therapy and slower tapering off of the prednisone. So these lower relapse rates in this case. For those that are not responsive to this, it may be due to maybe they have some underlying focal sclerosis that may be missed on the biopsy, or because when you sampled, you took a wrong section. So generally, the treatment is usually continued for about 1 to 2 years. However, half or even more of these are going to relapse and they may require treatment with the same regimen or even a different regimen. In some cases, we may consider other immunosuppressive therapies. So For those that are the steroid resistant, about less than 5% of the children and even more than 10% of the adults. Generally, these ones are the ones that are going to be frequent relapsers. And the corticosteroid dependent patients, then prolonged remission, you want to achieve this by giving them another immunosuppressive agent. So you can give them other drugs like cyclophosphamide, you may give them cyclosporin or tacrolimus, mycophenolate, and possibly even rituximab. So when there is a relapse on the steroid withdrawal, then cyclophosphamide should be added and you repeat the induction with the steroids. So you're going to give them a course of cyclophosphamide, about 1.5 to 2 milligram per kg daily for about 8 to 12 weeks. That's about 2 to 3 months, with the combined prednisolone, about 7.5 to 15 milligrams per day. And remember that steroid unresponsive patients may respond to cyclophosphamide. So no more than 2 courses of cyclophosphamide should be prescribed in children because of the risk of the side effects or things like azoospermia. An alternative to cyclophosphamide is cyclosporin, which can be given at 3 to 5 milligrams per kg per day. And remember that the choice of the drug that you're going to use is going to be influenced by what the patient prefers, the drug availability, how much it costs, how much they're tolerating this drug, and potentially the side effects that are there. In terms of prognosis, generally it's favorable, so more than 80% of your patients will achieve remission, and generally they may progress into renal failure in less than 5% of the patients, but this is more common in those that initially do not respond to the corticosteroids. I really hope you enjoyed this video on minimal change disease as an introduction to nephrotic syndrome on the channel. If you did, consider subscribing to the channel, hit the bell notification icon so you never miss on such amazing content every time I post to Zambia and beyond. My name is Dr. Moses Kazevu. Until next time, bye-bye.